Awesome. All right. Good afternoon, EO. It's great to be with you all. It's a slightly different time for these, but this is great. We're pleased to welcome back Dr. David Aronoff, the Director of the Division of Infectious Disease at Vanderbilt University Medical Center. Dr. Aronoff, thank you for joining us today. He's been highly involved in the diagnosis and clinical care of COVID-19, as well as serving in a pivotal role as key communicator of public health measures during the pandemic, through frequent media appearances, educational activities, and direct relationships with employers. I hate reading those things, but I had to read it, and I'm glad I did. So, you were great back, and you were with us, I think, in December of last year, and grateful for Judy connecting us all together. Everybody, there's going to be a little bit of different. We've done these EO exchanges a lot. Typically, we break out at the end. I think we should probably have enough questions today. We're just going to stay straight through and go with Q&A and not do a small group breakout at the end. So if you have questions, please put them in the chat, and I'll be sure to get to those after Dr. Aronoff gets to his presentation. So please take it away. Thank you.
Yeah, thank you, Richard. I really appreciate the invite to be back and speaking with you. Last time we spoke, things were a little bit different. And also I was having all sorts of AV issues, and I gave that talk on my cell phone, and I'll never forget doing that. But I'm really, really honored to be able to spend some time with you. And I'm going to go through a bunch of slides. I'm going to do it pretty quickly. So I will make these available to you. I'll send the slides your way. So don't worry about jotting links down or notes really fast. Really, I want to get to questions and answers. And so with that stated, I'm first going to just level set on where we are in the pandemic. And I updated these data yesterday evening, but of course, this pandemic continues to roll on and things are different already today. But if we look at where we are globally with the pandemic, it's still pretty active. In fact, disease activity is increasing in almost 50 countries around the world. And if we look at this heat map, where red means there's lots of activity of COVID-19 and green means there's less, the US is still pretty hot. We're one of the more active countries in the planet. If we look at case counts on a daily basis, that's what this graph is, starting at the beginning of the pandemic in late 2019, up until a couple of days ago. We really hit a peak in December. Things came down again, then they went back up. And fortunately, worldwide as a whole, case counts are falling, and they're close to 500,000 cases a day. That's a lot of cases a day. That's why we've already hit almost 230 million cases of COVID, and unfortunately are very close to 5 million lives lost. Both of these numbers are largely underestimates, by the way, because we certainly haven't diagnosed everybody who's had COVID or everyone who's died with COVID. Have we made the diagnosis? If we look at daily deaths around the world, they are downtrending. After a bit of a recent increase, they are starting to head down. So this is really suggestive that the major variant, which is the Delta variant, which we'll talk about, is actually starting to wane worldwide. If we look at the United States, this is a heat map where all these little tiny boxes are counties within the United States. And you can see a lot of disease activity and very few places where disease activity is relatively low. Yesterday, Tennessee was #1 in the country for disease activity. Today, actually, we've dropped several spots. Other states like Alaska have really risen. And if we look at cases again in just the United States, we're starting to hopefully curve and maybe start coming down. If we look at hospitalizations here, that's starting to come down. Deaths, which tend to be a bit of a lagging indicator, they follow the peak in cases, are still rising in the United States. I think this is a really interesting graphic, and this is basically charting the top 50 countries in the world for disease activity out of the top 200 or 195 countries. But for this exercise, these folks have treated the 50 United States as individual countries, just to see where we would rank in the top 195, for example. So if you look at the top 50 countries in the world, counting US states as countries, we would right now make up 29 of those. And Tennessee, as of yesterday, would be in the lead. I think now Alaska, which was third, has overtaken us for the lead. But there's a lot going on with COVID still in the United States. And if we look at hospitalizations, because I know people are asking about our capacity to care for hospitalized patients in the state of Tennessee, that's actually coming down now, which I think is really tremendous. These are dates of hospitalization and the number of people in the hospital across the state. And this is all in September here. We were at about 3,800 patients, and that's now below 3,000. The red line are patients in the intensive care units, which is still pretty flat and pretty busy. And then people on mechanical ventilators are shown in the blue line here, which is also maybe starting to decrease. I know at Vanderbilt, our ICU numbers and ventilator numbers are starting to decrease, which is fantastic. Kids are getting COVID-19 and they're getting infected with the Delta variant. The Delta variant, as I will mention, is highly contagious. It does not seem to be more dangerous to people than the original SARS-CoV-2 virus, but it is so much more contagious that we see a lot of people getting very sick, and that includes children. So we saw a peak in kids recently here in earlier September. That is starting to fall in terms of the number of children hospitalized across the state with COVID-19. We're seeing decreases in our ICU beds and ventilator patients for children. But mind you, these are kids, and recently we had over 80 kids across the state hospitalized because of infection from SARS-CoV-2, largely the Delta variant. So I do want to pivot and talk a little bit about variants, which really for now means talking about the Delta variant. If we look across the US and sample viruses for SARS-CoV-2 that people are being diagnosed with and ask what variant do they have, right now, almost 100% of the viruses we're sequencing across the US are coming back Delta. And that's been the case now for many weeks. So the Delta variant is problematic because it's so contagious. It's very sticky for us. In other words, the virus, which is a pretty simple little sphere, is covered in little spike proteins. And those spike proteins are like the Velcro that the virus uses to attach to the cells in our body. With the Delta variant, it has had modifications to that spike protein that make it very sticky, almost like super Velcro. And so we don't have to inhale very much of the Delta variant to set up an infection. In addition, the virus spreads from one cell to the next in our body very well, in part because of that sticky Velcro situation, and it builds up to very high levels in our body. So for example, the Delta variant is 2 to 3 times more contagious than the original SARS-CoV-2. So if I was infected with the original SARS-CoV-2 on average, if I didn't wear a mask, I didn't socially distance, and I wasn't vaccinated, I would probably infect about 2 or 3 other people. With Delta variant, that number goes up to 5, 6, or 7 people who get infected on average from one person with COVID if they're not doing anything to prevent the transmission. The Delta variant also has a shorter incubation period, that time between when I get infected and when my symptoms start. That can happen anytime between 2 days after infection to 2 weeks, but on average has been about 5 days. With the Delta variant, that average is now about 4 days. And as I mentioned, infected people shed over 1,000 times more of the Delta variant than they do the original SARS-CoV-2. So not only are infected people shedding a lot more virus, but that virus is stickier. So people don't have to breathe in very much. And that translates into lots of people getting infected. Unvaccinated people, as I'll mention, remain the most vulnerable to getting infected. But because we now have 3 different populations of people, we have people who have had COVID, they've recovered from COVID, they do have some immunity to getting infected, even with the Delta variant. We have people who are vaccinated, but then we have people who are neither vaccinated nor have they had COVID in the past. And those are the most vulnerable to getting infected today. But those 3 different groups create a bit of a patchwork quilt. And so we start to see outbreaks in communities that don't have very much vaccine and maybe were not taken up in terms of infection early in the pandemic. We're still seeing occasional outbreaks in incarcerated people or nursing homes where vaccines may be waning a little bit. We know for sure that infections can happen in vaccinated people, and I'll talk about that. And vaccinated people can transmit the virus. It's harder for them to transmit the virus, but it is possible for sure. And I'll show some data related to that. These are data that came out of Singapore looking at people infected with the Delta variant. And there are two types of people on this figure here. Red dots represent unvaccinated people who have the Delta variant, and each dot represents how much virus is in their nose when it is sampled. If you're up on this side of the graph, coming from bottom to top, you have a lot of virus in your nose. If you're down here on the graph, you have very little virus in your nose. And then this is time over here every day from the day that someone got diagnosed with COVID until a month later. So all these red dots are the amount of virus in the nose of people who were unvaccinated and got COVID from the Delta variant. The green graph are the people who were vaccinated, but they still got COVID from the Delta variant. And there's a couple of important points to make. First, on the day of diagnosis, the amount of virus in the nose is pretty similar, whether someone was unvaccinated in red or vaccinated in green. But the other important point is that over time, the people who are vaccinated appear to clear the virus more quickly from their nose, which likely makes them less of a threat to others. The other thing you should know is that this group of people, the vaccine breakthrough people, was significantly older than the unvaccinated people, because in Singapore, like in the US, it was older people that got vaccinated first. And it turned out this group of people, even though they were older, they were less likely to get severely ill than the unvaccinated people who were younger. So we learned a lot from this study. I now want to talk about vaccinations because, as we know, in late August, almost exactly a month ago, it'll be a month on in 2 days from now, the FDA approved the Pfizer vaccine, which is hard to pronounce, the Comirnaty vaccine, for people 16 years of age and older. And in fact, today, the Advisory Committee on Immunization Practices released their recommendations for using this vaccine in people 16 years of age or older. We're recommending vaccines for two reasons. One is to protect ourselves. We know that getting vaccinated reduces the risk of infection. That's true for the original variant, but also true for Delta. It reduces the risk of getting infected asymptomatically or symptomatically. And vaccines absolutely prevent hospitalization and death. Because they reduce the risk that we will get infected, they make it harder for us to participate in the chain of transmission to other people. And because we clear the infection more quickly, that makes us less of a threat to those around us. So we really do want to get vaccinated to protect ourselves and others. And I want to show some data that address a lot of questions. These are data that were recently released from the CDC that show that vaccination offers strong protection against COVID-19. And I'm showing you 3 graphs. This graph looks at just getting diagnosed with COVID-19 starting in the spring, late winter or spring of 2021 until late July. And we're looking at essentially the rates of infection in unvaccinated people in the black line and vaccinated people in the blue line. And after this solid line here, this is when Delta started to be the predominant variant in the US. Take a look at this. Cases, as we remember, were really falling, even in unvaccinated people. And then when Delta came, it started tearing through unvaccinated people. Vaccinated people were already less likely to get COVID even before the summertime. But we are starting to see more cases in vaccinated people with the Delta variant. And that's probably because some of the immune strength that people got back here is starting to wane. or go down, but also the Delta variant is a better virus, more capable to cause infection. But this difference is still quite significant. But remember, how would you have behaved back at the end of 2019 if I had told you that there was a new coronavirus for people, it's highly contagious, and all it causes is the common cold? I would argue you wouldn't have cared because the common cold is already quite contagious and already caused mostly by coronaviruses. But the reason we care about SARS-CoV-2 is that it kills people and it debilitates people and it puts people into the hospital. And we really need vaccines to prevent that. So if we look at hospitalizations from COVID-19, again, even in unvaccinated people, those were falling over the summer because disease activity was falling. But once Delta hit, hospitalization rates really kind of went vertical, which is what we've been seeing in the US. But look at the vaccinated people, almost no change in the incredible protection of vaccines. And with deaths, we see the same thing. The difference in risk of dying or being hospitalized between being unvaccinated and vaccinated is really strong. In fact, this graph summarizes these data, that even in the time of Delta, the risk of getting infected is reduced about 5-fold by getting vaccinated. The risk of being hospitalized is at least 10-fold reduced, and the risk of dying is also at least 10-fold reduced by being immunized. Some data that were published this summer that for a study that ended in May, so this is before Delta, estimated that vaccines up until May had averted somewhere around 140,000 deaths. Now in the US, we're approaching 700,000 deaths from COVID-19. Imagine if that number already was closer to 900,000 or 1 million. Vaccines have clearly helped prevent a lot of deaths, even just in the United States. And how are we doing vaccinating people? Well, fortunately, over 180 million people are now fully vaccinated. And I think that's fantastic. And since mid-August, we've vaccinated an additional 2 million people. We've administered over 380 million doses of these vaccines. That's important because we're watching every one of these administrations for safety data. We essentially have real world safety data on over 380 million administrations of vaccine. That's incredible. And that is really almost more data than we have for any drug that we've rolled out or any vaccine we've rolled out. And we've really done well vaccinating older adults. The total population, we've now vaccinated over half of the US population, but we have a lot of people who are still unvaccinated. This study, which came out of the Netherlands, shows that getting vaccinated can reduce the risk of transmitting the virus, even inside households, to unvaccinated people. Now, this study was done when the UK variant or the Alpha variant was prevalent in the Netherlands. The Alpha variant is also more contagious than the original SARS-CoV-2, less contagious than Delta. But when they looked at unvaccinated people who got COVID, they had about a 30% likelihood of passing that virus to a household member. If a vaccinated person got COVID, that risk was closer to 10%. In other words, about a 70% reduction in risk that somebody at home who was unvaccinated would get COVID from somebody who brought it in from outside. So I've said a couple things about vaccination. First of all, multiple studies show that vaccine effectiveness against getting infected is starting to decline a bit over time. It's still quite good, but it's declining over time. And this is driving recommendations for getting booster shots. The other, though, is that multiple studies show that vaccine effectiveness against severe COVID-19 hospitalizations and death remain quite strong. And that has been an argument against widespread use of booster shots, except for the people who are starting to get hospitalized after vaccine or starting to die after vaccine when they get COVID. And I'll talk about that group. A recent study showed that before Delta was predominant, vaccines prevented 95% of hospitalizations. During the Delta variant increase, as a whole, that dropped to only about 92%. So still very, very good against hospitalizations, but I'll show you more recent data since this. This is a very nice graph that brings together a bunch of different studies that looked at post-vaccine risk of getting infected with SARS-CoV-2. The studies are each in different colors. Some started back in February and some started in March. And I think you can see that protection against getting infected was greater than 70%, really around 90%, but from June to July started to drop to being closer to somewhere between 40 and 80% for getting infected with COVID-19 or SARS-CoV-2. And this has really gotten people excited about getting boosters. But if we look at these same studies and look at the risk of getting hospitalized, that protection has stayed pretty strong. This study was released yesterday and was led by investigators at Vanderbilt. The first author, Dr. Self, who you can barely read on this slide, but he's a Vanderbilt emergency department physician. A number of my colleagues are on this study. And they also looked at the effectiveness over time. So if we look at, and this is really looking at just hospitalization, protecting against hospitalization. So look at the Moderna vaccine effectiveness during the entire surveillance period was 93% effective. And if they just looked at people who were 4 months out after vaccination, that protection was still over 90%. With the Pfizer vaccine, the full protection was closer to 88%, so still very, very good, but a little less protective than Moderna. And after 4 months, that did start to drop to closer to 80%. And where these hospitalizations were being seen are more in older adults or people who got vaccinated early, 4 months before. These are the kind of data that are suggesting the need for boosters. I want us to be careful with these J&J data, because the J&J data, you can read this as suggesting that this vaccine is about 70% protective against hospitalization. And after a month, because there aren't as many data for J&J, that it stayed at about 70% protective. But be careful how you read these, because if you look at the case patients, these are the people who were vaccinated. These are small numbers, and only about 2% were getting hospitalized with COVID, which is similar to what was seen with Moderna or Pfizer. In the unvaccinated people, the folks who were compared to J&J, these numbers are also quite small. Only about 7% of people ended up hospitalized in this group. That's very different than what we saw with the Moderna and Pfizer, where higher percentages of unvaccinated people were getting hospitalized. It's hard to make a low number lower, even though Johnson & Johnson did that by about 70%. So I'm still not totally convinced that J&J is not pulling a lot of weight here, but this is the number that's out in the press for sure. Do I think the J&J vaccine is not quite as strong as a 2-dose vaccine? Yes, I do. I think this is going to be the first card to fall, but I do think it's doing really well at keeping people protected. All right. I do want to touch on vaccine safety. Lots of questions about this. Vaccines are really safe for COVID-19, and they're incredibly effective, as I showed you. The vaccines do not, with a capital D, capital N, they do not cause infertility. A number of studies have shown this, have looked at egg and sperm function and number, have looked at pregnancies. The vaccines do not affect fertility, and they are safe in pregnancy and breastfeeding. But we are seeing very rare side effects with these vaccines, literally lightning strike rare events. Anaphylaxis occurs with the mRNA vaccines to the order of about 2 to 5 events per million doses given. And we're using that information to say if you have a known severe allergy to one of the ingredients of the vaccines, the mRNA vaccines, you should avoid those vaccines. Myocarditis or inflammation of the heart is also very rare, single digits per million people. But if we look at males aged 12 to 17, that's occurring around 70 events per million doses given. Now, remember though, that COVID-19 also causes myocarditis. And if we look at the same group, males aged 12 to 17, that's about 450 cases of myocarditis from COVID-19, which the vaccine can prevent. Both of these numbers are really small. These are lightning strike rare events. Remember, the odds of becoming a lightning victim in the US in any 1 year is about 1 in 700,000. The odds of being struck by lightning in your lifetime is about 1 in 3,000. The risk of severe blood clots and low platelets with the J&J vaccine is highest in reproductive age women. It's about 9 events per million. We can use that information to say if you're a woman of reproductive age, you may want to get an mRNA vaccine to stack the cards in your favor against this very rare risk. The Guillain-Barré syndrome, which is a neurologic disorder, about 8 events per million J&J doses given. We have not seen long-term side effects from these vaccines. This was a real-world study from Israel that compared side effects of vaccines in almost 900,000 vaccine recipients to an equal number of unvaccinated people. Those are shown in these blue bars. And just to show you that the vaccines, compared to not getting vaccinated, had an increased risk of having lymph nodes that get swollen, almost an 80 times increased risk. Usually they're in the armpit, or shingles. Turned out to be increased risk of shingles after getting the COVID vaccine on the order of about 16 cases per 100,000 vaccines. They also did a study, though, to look at people who got COVID. These are unvaccinated people who got COVID, and compared almost 200,000 people with COVID to a control group and looked at the risk of these same adverse events. And there's the risk of having kidney injury from COVID is very high compared to the vaccine, or heart arrhythmias, or blood clots, or myocardial infarctions, which are heart attacks, or myocarditis, or inflammation of the lining of the heart, or blood clots that go to the lung. These were all significantly higher with COVID compared to getting vaccinated. And these are in people of all ages who are getting vaccinated in Israel, which I think was vaccinating at 12 and up. Now, I also want to put these risks into a different perspective for us. So a lot of these risks that we get worried about are happening in sort of 1 in a million shots. And I learned through the process of speaking and learning a lot about vaccine safety that there's actually a unit of measurement called a micromort, which is something that happens 1 in a million. That would be 1 micromort. So for example, if we look at the risk of adverse events from these vaccines and compare them to risks of death, it turns out that if a 75-year-old person gets out of bed, they have a risk of about 100 per million, or 100 micromorts, of dying, getting out of bed. Somebody riding a motorcycle 250 miles has a risk of dying during that bike ride of about 40 to 50 per million, or 40 to 50 micromorts. So you can put these risks of blood clots or Guillain-Barré or myocarditis into the risk of running a marathon, or dying while swimming, or dying while getting out of bed at age 1. You know, these sorts of things, just good to put in perspective when we realize that the risk of us getting COVID in the US is about 116,000 per million. The risk of dying from COVID is about 2,000 almost per million people in the US, or about 16,000 per million people who get COVID or have gotten COVID in the US. So just keep in mind that these are real risks, but they're also really small risks that we need to keep in perspective. The American College of Obstetrics and Gynecology and the CDC are recommending vaccination for pregnant people and those who are lactating. For people who also need to keep these in perspective about these side effects of vaccines, I can tell you that our hospitals are challenged to care for people because of COVID-19, not because of vaccine reactions. That's not who is in our hospital right now. What we're seeing in our hospital, and these are data from yesterday, across the Vanderbilt system, we had 166 patients in our hospital system with active COVID, 53 people we would say have inactive COVID. In other words, they've been hospitalized for a long enough time that they're no longer contagious, but they still came in with COVID. At the main hospital here, we had 100 people hospitalized yesterday, 12 kids, 28 in our Wilson County facility, and a little over 20 between Bedford and Tullahoma hospitals. And as of September 18th, for that week, ending September 18th, we hospitalized 164 patients in our hospital. About 90% of them were unvaccinated people. That was also true in our intensive care unit, and all of the ventilated patients requiring mechanical ventilation to live were unvaccinated people. The number of people who are vaccinated in our hospital are largely older and immunocompromised people, transplant recipients, chemotherapy patients, et cetera. Just want to talk about vaccination after COVID-19. So recovering from COVID-19 does provide protection from getting infected again. But immunity after natural infection wanes over time, just like immunity after vaccines can wane. Vaccines induce a more predictable, broader immune response than natural infection. And getting vaccinated after infection provides a strong boost to the immune system and better protection against getting infected again. And there have now been several studies that have shown that people who have recovered from COVID and gotten vaccinated have a lower risk of getting COVID again than people who recovered but did not get vaccination. And studies are clearly showing that getting vaccinated after having COVID is safe. Boosters are going to be recommended, but they are likely to be recommended for older adults first, or people at high risk for severe infection. Frontline healthcare workers, those with high risk for occupational exposure are likely to also be included. The Advisory Committee on Immunization Practices is meeting tomorrow and the next day to also give recommendations about boosters. We currently are vaccinating adolescents. We're not sure yet when we will vaccinate younger people, but probably by the end of October, we could see emergency use authorization for 5 to 11-year-olds. Granted, that will be with a lower dose of the vaccines than we're giving to adults. And then finally, about prevention, everybody on this call knows that we've seen mandates about getting people vaccinated in businesses. We're mandating vaccines here at Vanderbilt, both at the university and in the medical center. Vaccines belong as part of the Swiss cheese model that I've talked about before for preventing this virus from getting inside of us. Every one of these things, from wearing masks to social distancing to getting vaccinated, helps reduce the risk of a transmission event occurring. Vaccines are not perfect. They do have holes in them. But the more of these we can layer together, the more likely it is that we stay safe. So I'm just going to conclude by saying COVID-19 remains active. Vaccination is an imperative goal. Vaccines are safe and effective, but we should remember there are other ways we can protect each other. We all need to be leaders, and everyone at EO is a leader. And I think being able to help people in your household and your community understand that we're not quite out from under the pandemic yet, but we have many more tools to get there, I think is encouraging. I'll stop there and I'll stop sharing my screen and be able to take questions. So thank you. I hope that didn't go too long.
Oh, it's perfect. Thank you. Thank you so much for all the preparation and the work. So I'm just going to start running through the chat and I'll try to read them. And Marla, I never saw if you got the ones from the emails before, so however you want to do that, just let me know. I'm just going to start at the top. George is asking, if you get a J&J shot, do you have to get a J&J booster, or can you get Moderna or Pfizer? Do you have to stick with the brand, or can you change?
Yeah, George, thanks for that question. That's a really important question. So far, what we're seeing from the studies of mixing and matching is that it looks very, very good to be able to give an mRNA vaccine after an adenovirus vector vaccine like the J&J vaccine. Most of those studies have been done in Europe where they're not really using the J&J adenovirus vector vaccine. They're using the AstraZeneca, which is a slightly different one, but technically similar. I don't have any reason to think that using the mRNA vaccines to boost J&J or the reverse would not be effective. They all target the spike protein. They all lead to a very strong boost of immune response, similar to getting a vaccine. Even one dose of an mRNA vaccine after COVID-19 can provide a tremendous boost, even though obviously the mRNA vaccine is just one piece of the virus. So the problem, though, is that we just don't have guidance yet. And so we have to wait for the Advisory Committee on Immunization Practices. We really need to wait for J&J to submit a filing for boosters, and whether they will pair up with someone like Pfizer or Moderna to say, hey, can we use Pfizer or Moderna to boost our vaccine, is a little bit hard to know, because they want to get the revenue from using their vaccine too. So I don't know how all that's going to play out. But scientifically speaking, yes, you should be able to boost one with the other.
Perfect, thanks. Ken's questions, please address treatments for those diagnosed with infections prior to hospitalization. And on the back end of that, are there people who should not get the vaccine?
Yeah, I just gave a talk yesterday on treatment of patients in the outpatient setting. So first of all, there's really sort of one major therapy that's targeted against the virus that we're using in outpatients, and that's monoclonal antibodies. Monoclonal antibodies are antibodies very similar to the ones your body makes in response to either getting infected or being vaccinated. And they're meant to help deliver to you antibodies that are targeting that spike part of the virus, so that you can block the virus from infecting your cells or causing or spreading within your body and helping your body clear the infection faster. And it is very clear that if we use monoclonal antibodies as a one-time infusion in people who have symptomatic COVID, and they are within 10 days of symptoms, and they have pre-existing risk factors for ending up in the hospital, that we can block them from going to the hospital by using monoclonal antibodies. There are also studies that show that for people who are at high risk for doing poorly with COVID or ending up hospitalized, that we can use monoclonal antibodies right after they get exposed to someone with COVID and prevent them from getting hospitalized or very sick with COVID. And in fact, the Regeneron antibody cocktail can be used under the emergency use authorization for post-exposure prophylaxis. The problem is the supply. We don't have a lot of the monoclonal antibodies. So most places are not yet using the Regeneron product for post-exposure prophylaxis. We're using it to treat people who are symptomatic to keep them out of the hospital. And we are prioritizing the use of that therapy for people, number one, who are at high risk of getting hospitalized. Think older people over 65, people with obesity, diabetes, high blood pressure, any one of those things, organ transplant recipients, et cetera. And within that group, we're prioritizing unvaccinated people because they're the least likely to have their own antibodies that are protecting them from getting hospitalized. We originally were not restricting the use of monoclonals to people who are vaccinated or unvaccinated because we had a lot of the monoclonal antibody. But we don't have a lot of it now because so many people are using it. So we're basically reserving it for unvaccinated people, or at least prioritizing it for that group who are at high risk of doing poorly. There are some data to suggest that inhaled corticosteroids may be useful in the outpatient setting, that certain antidepressant agents, which have immunomodulatory functions like fluvoxamine, may be useful in the outpatient setting, but the data are not quite firm enough to really say we should be using those drugs. And some of those drugs have side effects, which we need to be very careful about. So both the NIH and the Infectious Disease Society of America are not yet recommending steroids for outpatients who don't require supplemental oxygen or fluvoxamine. We're not using ivermectin. The data to support the use of ivermectin is poor. And so we're not using that drug in the outpatient or inpatient setting outside of clinical studies. But there are clinical trials going on that I think are very robust that could shed light on drugs like ivermectin or other medications. So good question. I hope that that at least partially addresses it.
Right. Just to finish that one, he is also asking, are there people that should not get vaccinated?
Are there people who should not get vaccinated?
Yes.
Well, right now, we shouldn't really be vaccinating people for whom there's not an emergency use authorization or approval. So for now, that's people younger than 12. They really shouldn't get vaccinated until we've had a good ability to look at the safety data, look at the efficacy data, and hear from our trusted experts who are at the Advisory Committee for Immunization Practices. Dr. Kip Talbot, who's one of my colleagues here, is a leader on that group, and they'll be meeting tomorrow to talk about boosters, but they'll also be looking at the data for children. So those are groups of people who we shouldn't vaccinate. There may be people who are allergic to both vaccines, like the adenovirus vaccine and the mRNA vaccine, who maybe shouldn't get vaccinated. But honestly, it's really hard to think of people who absolutely shouldn't get vaccinated. There are very few medical exemptions to getting vaccination. So it's hard to even come up with good examples. If somebody has a hypothetical, I'd be happy to hear it.
Gotcha. Thank you. Mr. Bush is asking, ivermectin, take it or not?
Not right now. Keep in mind that if we look across the state of Tennessee, which mirrors the rest of the US, for every 100 people who get diagnosed with COVID, 2 to 3 of them will end up in the hospital. And 1 of them out of 100 will die of COVID-19. What does that mean? Well, first of all, that means it's a lot more dangerous than influenza. And if you get enough people infected, you see a lot of people getting hospitalized and dying. But it also means that if 100 people come to me today as a doctor and say, we have just been diagnosed with COVID, I could take a magic wand, in this case, my pen, and I could wave it at each of them and tell them that this magic wand is going to keep them from dying and keep them out of the hospital. And honestly, I'd be right 97 to 98% of the time, right? Because 98% of them aren't going to be in the hospital and 99% of them are not going to die. And for the 1 person that dies or the 2 people in the hospital, I could say, oh, I must have just like flicked it weird or something, I don't know. But you could see that it worked for all these other people. And that's the problem with a disease with where so many people get infected and do okay or recover, is that it's easy to believe that almost anything that has a good idea behind it is working. That's where hydroxychloroquine was. In the lab, it seemed to have activity, and then everyone got excited, but then large, very good clinical studies showed that it didn't help at all. Ivermectin's kind of in that same camp, where there were some reasonable ideas to think that it might be a good drug. And there have been some good studies that have not been promising, and a bunch of really small studies, kind of like my magic wand study, that just haven't been convincing. What people also need to realize is that for hospitalized patients, a lot of what we do that helps get people out of the hospital, right now, about 12% of the people we hospitalized at Vanderbilt are dying of COVID. So 80 to 90% of the patients are leaving the hospital, and that relies a lot on just good medical care, paying attention to fluids, paying attention to people's labs and getting blood cultures and starting antibiotics judiciously and using steroids like dexamethasone or antiviral drugs like remdesivir. And so we are not using drugs where the evidence base isn't there, where the guiding bodies like the NIH or IDSA are saying don't use them outside of a clinical trial. Now, that being said, we are doing large clinical studies, and we are participating in clinical studies that include medications like ivermectin. And it's through those studies that we're going to learn if that's really just a magic wand placebo kind of effect or no effect, or if there really is a signal there. So I strongly advise people not to use experimental drugs outside of clinical studies, especially for disease where we already know what the risk factors are for doing badly, and we can care for people who are in those high-risk groups. So I hope that's helpful.
Thank you. Vicky's asking, is it fair to say that those with natural immunity do as well statistically as vaccinated? Most of the studies have been comparing vaccinated against non-vaccinated. If someone has natural immunity, do they fall into the vaccinated category in your data?
Yeah, really great question. So it is very clear that people who have had COVID And by that, I mean particularly people who went to go get diagnosed with COVID and were symptomatic with COVID, that when they recover, they have protection against getting COVID again, including by the new variants that are out and about, like the Delta variant. A couple things to point out. People who had asymptomatic COVID or very mildly symptomatic COVID don't seem to mount very strong immune responses and seem to have higher risks of getting reinfected than people who are symptomatic. So that's one thing to keep in mind. The second thing to keep in mind is that we are clearly seeing second and third infections, mostly second infections in people who have had COVID before, because that immunity, like with vaccines, does wane over time. And the last point, which I made earlier, is that it's very clear that people who have had COVID before can get reinfected, but that risk can be reduced through vaccination. So even though having COVID in the past protects you from doing badly if you get COVID again, assuming that you have a normal immune system, getting vaccinated makes it harder for you to get COVID, which also then protects people around you, which again is super important in a pandemic. We're trying to make it through vaccination that people not only get individual protection, but they protect people around them, particularly children or more vulnerable adults. So, and then recently we're seeing studies that are fascinating that show that getting vaccinated after infection actually leads to a much more diverse group of antibodies that protect against potentially newer variants better actually than having infection by itself, or even better than just getting vaccinated. The problem is, of course, we don't want to prescribe for people go out and get infected and then get vaccinated, because if we do that, we're going to kill people. But if somebody was vaccinated first and they ended up getting COVID after vaccination, they probably are getting a very robust boost from that natural infection. So if you gave me a time machine and a choice, would you rather get COVID first and then vaccine, or vaccine first and then COVID? That's a zero-brainer. I would much rather be vaccinated and then survive without complications or long COVID, my infection, and know I'm still getting a boost from that infection. The reality is I don't want anyone to get COVID. First of all, I don't want people to get complications like dying or getting hospitalized. But second of all, I don't want them spreading it to people who have those same problems, or people getting long-term consequences of COVID. And we know now that the vaccines do protect against long-term consequences of COVID, even when people get breakthrough infection. And a large British study recently showed that quite nicely.
Thank you. Thank you. Bridget is asking, what is the status of the Mu variant and the other potential variants, and how do they compare to the original variant and the Delta variant?
Yeah, I mean, all of these new variants, we're going to just keep learning about these variants because, you know, this virus is new to people. It's continuing to spread a lot, particularly in unvaccinated countries. As I mentioned, there's about 50 countries in the world where rates are still going up. And as the virus, every time it replicates, it's prone to some errors in its genetic code. And sometimes those errors in its reproduction can change the structure of the virus. Sometimes they change it for the worse for the virus, like the new version, the new mutant actually doesn't survive very well. It is less sticky for other people. But every once in a while, you get something like a Delta variant or an Alpha variant or a Mu variant where that Velcro becomes more sticky, where it's better at evading our antibodies. And that's what we're watching for, doing all this surveillance around the world, sequencing viruses, looking for variants. And the more viruses we sequence around the world, the more we find these variants. Some are more major changes to the structure of the virus than others. So far, we really have not seen a variant that's more contagious than Delta. Delta remains almost 100% of the virus we're seeing in the United States. And I check that almost every day. It has really made a foothold. Are we likely to see another one take over? Yeah, we're likely to, but it's quite possible, like with Delta, that our vaccines will still be very protective. Remember, as I showed you, yes, more people are getting infected after vaccination with the Delta variant than they were in the past with the original one, but But also the vaccines are keeping people out of the hospital. They're protecting against death. And I think that's going to be the case with Mu or these other variants, that the vaccines are going to do the heavy lifting for us. They're going to keep people safe, which is really the most important thing that they can do. A year from now, are we going to need a booster, everybody? Or 6 months from now, not just older adults need a booster? Maybe. We're going to have to keep our eye on disease activity, hospitalizations, and variants that are out there. But we're pretty used to getting annual flu shots. And I think if we have to do an annual booster for COVID, that's okay. People are already starting, like Moderna's already starting to make combination influenza COVID vaccines that they're trialing, because once you have this mRNA technology, you can really multiplex the vaccine. So it may be that we get fewer shots as we do those sorts of boosters, but hopefully that answer is helpful to you.
Thank you. There are a couple in here. We're getting close on time, so we'll see if I can combine.
I'll try to be quick. I'm a talker. I apologize.
No, you're doing great. I'm so thankful. Thank you. Some people are asking, and I'm one of these actually, about making decisions on going and doing things like, going to a football game or going to a concert, whether it's a concert that requires people to be vaccinated or going to a football game that's outside. I mean, making those go no go decisions can be difficult. And so how do you process those, or how would you suggest people try to process those? And is that even a very fair question? I don't know.
Oh, it's a super fair question, and it's a real world question. It's one we have to ask all the time, because we know if every human being were isolated from every human being, there'd be no contagious disease problems, which would make my job go away, which on the one hand would be good, but on the other hand, I'd be unemployed, which would be bad. So I'm glad people get together, because at least that keeps infection somewhat going around, I guess. That's no, but to be serious about this, I think it is always safer right now for people to be gathering who are fully vaccinated, and for people who are at high risk of doing poorly or having vaccine responses that are not normal, like a kidney transplant recipient or someone undergoing chemotherapy, to avoid crowded indoor areas, or people with multiple health conditions, high blood pressure, obesity, diabetes, who, if they're unvaccinated, should really, really be careful going into crowded public indoor or outdoor venues. But, if everybody in a facility is vaccinated indoors, and people are cognizant and respecting space between each other and hopefully wearing masks, that's relatively, on the relative scale, that's a relatively safe situation. Going in and dining in a restaurant, if the staff and you are fully vaccinated, even if you don't know if everybody else is fully vaccinated, that's a little higher risk. But you go in, you eat, and you don't dilly-dally and you get out, you've put yourself at some risk, but because you're vaccinated, you're unlikely to get super sick if you get COVID-19, and you make that decision to go to dinner knowing, is there someone in my household who could get really sick? Because if there is, maybe that's not for you going to dinner just yet, until that person is protected in some way, either through vaccination or monoclonal antibodies or whatever. So I think we're still making those game time decisions, looking at these pro football events and college football events, lots of crowding, bottlenecks at restrooms, lots of crowding outdoors, nobody wearing masks. I'm confident some people are going to die as a result of those things. But a lot of the young people who are vaccinated are not. And I think as a society, we're sort of seeing people rushing in because they've been cooped up for 18 months. But for me, that's why it's so important for me to be getting people vaccinated. I want people to be going to watch football games and basketball games and soccer games and being at concerts. And if people are just going to be doing those things, then I have to rush around and make sure I'm doing all I can to protect people, which is why I need your help. It's why I need you all to make sure that the people under your charge are aware that it's really important to be vaccinated, because we don't want somebody who's at a college football event to die or somebody at home to die. And the way that we're going to protect them is by getting ourselves and hopefully them vaccinated.
Thank you. And then, so we got time for one more. I'm going to scroll really quick.
Sure.
All right.
These are
So
amazing.
this is a good one. What's that?
These are amazing questions.
So this is I like this question actually. It's a silver lining question. So what advancements in the practice of medicine have occurred due to this pandemic, other than the obvious as the vaccine, as a new vaccine?
Repeat that question for me. I want to
So
make sure.
what advancements in the practice of medicine have occurred due to the pandemic, other than the obvious, which is the vaccine?
Yeah, I mean, obviously the mRNA vaccines have been a great game changer. A couple of things have really changed. One is we've recognized that in the time of crisis, we can do properly conducted clinical trials of medications and vaccines really, really quick if we mobilize resources, money, people, computer systems, IRBs, hospitals. We can do studies quickly and accurately and effectively. That's fantastic. We also know that we can provide a lot of help to people through telehealth. We were just sort of dabbling in that as a medical community before. We've also learned a lot about the importance of health equity. So when people ask me, how do we prepare for the next pandemic? I don't go to the lowball answer, the low-hanging fruit of, well, we need a vaccine against all viruses, or we need better surveillance systems. The reality is, to prepare for the next infectious disease pandemic is we need our population to be healthier, because COVID-19 has been disproportionately preying on people who are less healthy. And a lot of that is reflected in health disparities. Our healthcare system, as Walter Cronkite once said, is neither healthy nor caring or much of a system in the United States. And there's a lot that we need to do to improve health equity in the US. And this pandemic, as a silver lining, has helped us recognize some of the really great chasms in the way that we provide care. So I think that's an area that is going to benefit from all of the sadness of the pandemic. At least I'm hopeful for that being the case.
Perfect. Thank you. And thank you for taking this time and helping to educate us and answer our questions. If I missed a question there, guys, I'm sorry. Maybe we could do an email and try to get them off somehow. Samara, Marla, do y'all have opinion on that?
If the doctor has time to deal with that.
I sure do. Yeah, I mean, send me questions. I'm happy to try to turn them around as quickly as I can. I care about you, and I want you to have the information that you want to have. I'm very thankful of your time, and I'm not hard to find, and still doing COVID 7 days a week. So if you need me, I'm here.
Thank you so much. And thank you everybody for joining, and tell your friends to watch it on the recording.
Excellent.
All right, guys.
Thanks, everybody.
Thank you so much. So great.
Thanks.
Thank you. That was amazing and covered everything.
Oh, good. I hope that was on target for y'all. The questions were spectacular. I'm sorry if I babbled a bit too much.
No, we could sit and listen to you for 3 more hours, which you're like, really? I would like to leave now.
That's funny. Yeah, I wish my kids felt that way for even 5 minutes. It'd be fantastic.
Don't we all? Don't we all? For sure. Well, it was amazing as always. And thank you for all you're doing for